Hi students, this is Mrs. Egler and this is chapter 39, Oxygenation and Perfusion. We are going to go through this PowerPoint today. In the beginning, we have a lot of anatomy. The book starts off with a lot of anatomy and explaining the respiratory system and a little bit of our cardiac because of perfusion and how that affects oxygenation. I know you've all had anatomy, so the beginning of these PowerPoints, I'm just going to briefly run through anatomy on the slides, and then we'll get into more of the content as we go through the PowerPoint. So when we think about the anatomy of our respiratory system, we want to ask ourselves, well, why is this important? And basically, it is the pathway for transport and exchange of oxygen and carbon dioxide. So if we understand the role of our respiratory and our cardiovascular systems, we have a better foundation for understanding and assessing oxygenation in our patients. And this assessment, when we are assessing that oxygenation of our patients, can assist us in planning and determining what interventions we are going to want to promote for that optimal oxygenation. So as we get started, as I said, we're going to run through the anatomy of our respiratory system. So just a basic overview, the respiratory system consists of our airway, which begins at our nose and ends at the terminal bronchioles. We have our upper airway, which consists of our nose, our pharynx, our larynx, and our epiglottis. Then our lower airway is our trachea. We have a left and right mainstem bronchi, segmental bronchi, and terminal bronchioles. The mucus, so we have mucus within our nares and that lines our airway, and that helps us trap debris and protects us from or protects our underlying tissues. And then we have cilia, which help propel trapped material up the airway. The thinner that our mucus is helps with this process as well. So when we think of our respiratory system, we need to think of all these different parts that make up our respiratory system. As we continue on, our respiratory system is also composed of our lungs. So our right lung has 3 lobes and our left lung has 2 lobes. They're composed of elastic tissue. And this is good to think about because as we start to age, we may see a decrease in the elastic tissue, which is going to cause some compliance problems with having that lung being able to expand. So we'll talk about that in a few slides down. We also, within our respiratory system, have alveoli, which are small air sacs at the end of the bronchioles. They're made of single cell layer of squamous epithelium. They're covered in capillaries, and this is our site for gas exchange. So if we have a surfactant, reduces surface tension in our alveoli, helping prevent their collapse. As we continue to review our anatomy of our respiratory system, we have pleura, and this is our serous membrane. The visceral pleura covers our lungs. The parietal pleura lines our thoracic cavity, and these are continuous and form a sac. The sac is filled with pleural fluid. This fluid is lubricant, and this is what allows our lungs to easily move along the chest wall. The physiology of our respiratory system, so pulmonary ventilation, we have the movement of air in and out of our lungs, and this takes place with 2 steps, inhalation and exhalation. With inhalation, our diaphragm contracts and descends into the thoracic cavity. This is the active phase that brings air into our lungs. The next phase, exhalation, diaphragm relaxes. This is the passive phase where the air moves out of our lungs. Air moves from a greater pressure in the lungs to an area of lesser pressure outside of the body within this phase. Some other factors that contribute to airflow in and out of our lungs is our compliance of our lungs. So as I mentioned earlier, our ability of our lung to be inflated depends upon its elasticity. So there are conditions such as emphysema as well as aging that cause that decreased elasticity or that compliance. And so if you think about it, the ability of the lung to inflate depends upon its elasticity. If you think about trying to blow up a balloon, um, and it doesn't want to blow up very easily, that can be what you can think of when you think about compliance and that elasticity. Is it requires a greater inspiration or a greater push of air to inflate those lungs. So compliance will affect the amount of oxygenation a patient has, and how much effort it takes to actually inflate their lungs while they're breathing. Airway resistance is another factor when we're thinking about our respiratory system that can have an impact. And so, any process that changes the bronchial diameter or the width can cause a resistance, which can impede that air movement into the lungs. So, any obstruction, whether it's a foreign body, tumors, maybe the patient's really ill with pneumonia. They may have this thick mucus that kind of blocks that airway, or some conditions such as asthma, which kind of constrict or narrow that airway, are going to cause airway resistance, and they're going to impede that air movement into the lung. As I said earlier, with our respirations, we have gas exchange. So respiration involves the gas exchange between the atmospheric air in the alveoli and blood in the capillaries. This gas exchange, as I said earlier, occurs in the alveoli, and it takes diffusion, which diffusion, I don't know if you had that in anatomy or biology, is that movement from an area of higher concentration to lower. So the greater the pressure of oxygen in the alveoli causes it to move to the capillaries containing the unoxygenated venous blood. And then carbon dioxide in the venous blood exerts greater pressure than the carbon dioxide in the alveoli, and therefore carbon dioxide diffuses across the capillary into the alveoli, and then that is exhaled. Gas exchange and diffusion can be affected by, as I said earlier, surface area, so loss of tissue or any tissue damage, incomplete lung expansion or collapse of the alveoli. Can prevent those pressure changes. Again, obstruction, just immobility, and us not expanding our lungs as fully. So make sure you are, again, that's why I said it was important to understand the anatomy so that we can realize if our patients have some of these problems, we will realize that that's going to affect their gas exchange and their oxygenation. We're still in some of the slides with anatomy. So I kind of talked about what our airway system consists of and having adequate, being able to inhale, exhale, and what's involved with those systems. So we also have to have adequate perfusion. So our blood carries our oxygen to our tissues, and this is dependent upon that adequate blood supply and our cardiovascular function. Regulation of our respiratory system is done within the medulla. So we have, or it is stimulated by increased concentrations of carbon dioxide and hydrogen and decreased amounts of oxygen in the arterial blood. The medulla sends an impulse down the spinal cord to the respiratory muscles to stimulate an inhalation. If we have a patient that has conditions that causes chronic changes in their oxygen and carbon dioxide levels, then we may see that their chemoreceptors become desensitized and they are able to really regulate their ventilation adequately. And that is based off of this drive or the stimulation within the medulla. So alterations with our respiratory function. We've went through our anatomy. If we have any problems within ventilation, respiration, or perfusion, then that will develop into hypoxia. And hypoxia is an inadequate amount of oxygen that is available to the cells. It's often caused by hypoventilation, so a decreased rate or depth of air movement into the lungs. And so some signs of hypoxia include dyspnea, which is just difficulty breathing. And so, with somebody cannot, or they're having difficulty breathing, you may also see correlate with that an elevated blood pressure. They're going to have an increased respiratory rate and a pulse rate because they're working harder to try to get that air in. They may seem pale. You may see some cyanosis, so some bluish tinge to maybe their lips, their fingertips. The big thing is when you can't breathe and you can't catch your breath, you may also become very anxious. Anxiety may set in, which then even increases more of your respiratory rate that's going on. You may see the patient become restless. If you suddenly have a very restless, confused patient, or they become very drowsy all of a sudden, you're probably going to want to check a pulse ox to see what it's registering and what is their oxygenation, because those kind of go hand in hand as well. If we have a patient that has chronic hypoxia, which some conditions can cause that, some I'm thinking of are emphysema, COPD, or chronic obstructive pulmonary disease, you will begin to see that hypoxia being detected in all the body systems. So they can be manifested as an altered thought process. Maybe the patient has headaches or chest pains. We may start to see that they have an enlarged heart, clubbing of the fingers and toes, anorexia, and constipation. They may begin to have some decrease in their urinary output, weakness of their extremities and muscles, and also muscle pain. So oxygen, as we said, and carbon dioxide must move through the alveoli and be carried to and from body cells by blood. And this is why we have to have an adequately functioning cardiovascular system in order to have that exchange of gas. So again, this is just the anatomy of the heart. You probably had that in your anatomy class, but the heart has valves. The atria are the two upper chambers. They receive blood from the veins, and the ventricles, the two lower chambers, send blood through the arteries. And then when we think about the pumping of the heart, we have a stroke volume. So that's the quantity of blood forced out of the left ventricle with each contraction. And our cardiac output, the amount of blood that's pumped each minute. Cardiac output is equal to the stroke volume by the heart rate. We are not going to ask you a test question on that, but just realize that having a heart that efficiently pumps is very important to our oxygenation system. The physiology of our cardiovascular system, oxygen is carried primarily by our red blood cells and just a small amount via plasma to the tissues of our body. The hemoglobin in the RBCs has a strong attraction to oxygen, and therefore about 97% of oxygen is carried in the form of oxyhemoglobin. And once those red blood cells reach the tissue, we will see internal respiration must occur. And all that means is internal respiration is the exchange of oxygen and carbon dioxide between the circulating blood and the tissues and cells. So based on this, this physiology of the cardiovascular system and how our oxygen is carried in our hemoglobin, that can be, if our oxygenation can be affected by any abnormality in blood components. So if you have a patient that's having a hemorrhage or they have anemia, you're probably going to see maybe that have an impact on their oxygenation. Another one I think of is sickle cell disease. And so just being aware that if you have somebody coming in with those conditions, you're going to want to be looking at their RBCs, their hemoglobin levels, and keeping an eye out on their oxygenation levels. So, cardiovascular blood flow, the muscles of the heart have their own blood vessels that provide oxygen and nourishment and remove waste products. The main blood vessels are the coronary arteries. And as we get into in the next slide, any alteration in that will also affect oxygenation of the patient. So, alterations in our cardiovascular function. Um, Patients with dysrhythmia, this is a disturbance in the rhythm of the heart or some kind of abnormal conduction, whether it's regarding, or whether it's from hypertension, heart disease, heart damage. But this can decrease the oxygenation because the heart is not pumping effectively when a patient's having a disturbed rhythm. Heart failure is another alteration in cardiovascular function that will affect our oxygenation. The heart is unable to pump sufficient blood supply. There's multiple causes for that: hypertension, coronary artery disease, heart valve disease. But some signs and symptoms you'll see with heart failure are shortness of breath. The patient will have some edema and fatigue. And then the last one, myocardial ischemia. So again, when I said that the heart has its own blood supply to it, if we have any decreased oxygen to the heart, such as a blockage, the patient can experience chest pain. They'll experience an imbalance between the amount of oxygen that's available to the heart and the amount needed by the heart. And this can cause a myocardial infarction, which is basically death of heart tissue. So the patient ends up suffering a heart attack. But when the patient presents, you may see them having, like I said, the chest pain. They'll have the anxiety because they can't breathe as well. They may be nauseated and have some vomiting. They may feel like they have indigestion. But another big one is they will be very short of breath. So those are alterations in cardiovascular function that affect oxygenation in our patients. So factors that will affect a patient's cardiopulmonary functioning and oxygenation. So your book goes in to discuss several things. The first is they're just in general our patient's level of health, and some of these we've already hit on. Renal conditions, so if the kidneys aren't functioning properly and they are not excreting urine out because they're not functioning at full capacity, this can cause fluid overload in the patient, and it can impair with fluid overload, the heart can't pump as efficiently, and that can impair tissue perfusion and oxygenation. As I've already stated earlier, we want to watch our patients with anemia because we know oxygen is carried via the hemoglobin. So those patients' oxygenation could be affected. Weakened muscles, just a sedentary lifestyle, can really affect how well we are able to inhale and exhale and breathe. As I just got done talking about any damage to our heart muscle, we don't perfuse as well. And then there's been there's been a correlation between obesity and patients having conditions like chronic bronchitis. And it's thought that those who are obese are often short of breath during activity, which ultimately leads to less participation in exercise. And as a result, the alveoli are rarely stimulated and they don't expand fully. So there is some correlation between, again, that sedentary lifestyle and obesity and muscle weakness or poor muscle tone. And some of these, again, we've already talked about, but just being aware that the diseases or conditions that affect our cardiac and our cardiopulmonary and our oxygenation, our level of health, and these are listed here. Your book goes on to talk about developmental considerations being a factor that affect our cardiopulmonary. And although we won't test you on any pediatric patients, it is good to be aware that infants have a short airway. Their surfactant isn't formed until 34 to 36 weeks in utero. So if they're born prematurely, they may not have that development of that yet. But this is why infants have an increased respiratory rate, and their normal rate runs at 30 to 55. And when we look at an infant and their breathing, their respirations are primarily abdominal, so you'll see more abdominal breathing with that patient. Toddlers and preschoolers sometimes have an increased risk for colds and infections, and that has to relates to where their bronchi or their bronchiole are elongated, but they're less angular. And then again, we kind of talked about already the older adult, as we age, that elasticity of the lung and heart tissue decreases. The muscles of our respiratory system of inspiration and expiration can be more weak. Airway collapse easier. So just that older patient in general, we're going to want to consider them and keep an eye on them for cardiopulmonary alterations or alterations in functioning. Medications are another consideration when we're thinking about cardiopulmonary functioning and our oxygenation. And that's just because many medications can or any medication that has an effect on our central nervous system, we need to be monitoring carefully for respiratory complications. An example of this would be pain medications or opioids. That can depress the medullary respiratory center, and that can cause a decreased rate or death of respirations. So we definitely want to keep an eye on our patients as far as how much pain medication they're getting, how often they're getting it, how is their oxygenation. After they take the med, we want to go see how they're reacting to it. Check a set of vitals if we need to, based on this information. The next one your book talks about is lifestyle considerations. We kind of mentioned this briefly when we talked about obesity, but just that sedentary lifestyle can impact or decrease pulmonary and circulatory functions. It also can decrease the ability to respond to stressors and illness for that sedentary person. It's thought that the activity patterns do not encourage the expansion of alveoli and development of pulmonary exercise patterns or deep breathing for those who have a sedentary lifestyle. Your book goes on to talk about considering cultural implications, and understanding a patient's cultural background is necessary to promote health and disease prevention. And lastly, a good example might be cigarette smoking, for example, is a major, when we think about that in culture, maybe depending on how they were brought up or what is important to that person, what they value, we want to try to promote strategies that encourage that person to stop smoking cigarettes, because as we know, cigarettes are a major contributor to lung disease, to respiratory distress, heart disease, lung cancer. They're one of the most important risk factors for a patient developing COPD. So it's very important to try to work with that patient to have them understand the implications if their lifestyle is one that they are a smoker. Other things to think about: environmental considerations, just occupational exposure. Where do they work at? What are they exposed to in those areas? Air pollution. I know some patients who have severe asthma, depending on times of the year, if the air pollution's bad, that can cause them to have problems with their oxygenation and breathing. So just being aware of lifestyle considerations when we're taking care of our patients and how that can affect their oxygenation. So the beginning of this PowerPoint, we've reviewed anatomy of our respiratory and cardiovascular systems. We've kind of reviewed, or we've went over our factors affecting these systems and how they can affect those systems. And we are moving on to how we assess our patient. And so the first thing when a patient comes in is we want to get that nursing history. We want to interview that patient. We want to try to identify any current or potential health concerns and needs that they may have that we want to keep an eye on. And then your book, I was looking through, and it's called the Focused Assessment Guide 39-1. It's on page 1493, and it gives great kind of suggestions for factors to assess and what are the questions that, or how should you approach that. So when you're trying to assess their usual pattern of respirations, questions you could ask your patient in a history would be, how would you describe your breathing? Do you have any allergies? What type of allergies do you have? You may go on to say, do you have any difficulty breathing when you're having allergy issues? We always want to know what kind of medications they are taking. Any health history. Do they have heart and lung and breathing conditions? Lifestyle and environments, as we talked about, we want to know if they smoke, if they've had any recent cough, sputum, what color is it, are they ever short of breath, and are they having any fatigue? And so it gives this kind of overview of things you should assess for with a nursing history and kind of the appropriate questions you can ask your patient to try to get that information. So I highly recommend having a look at that. And then our next slide, we're going to talk about what we assess for physically on our patient. The next part, as we are assessing our patient, is our physical assessment. So when we walk in the room, we want to look at our patient. Do they have any signs and symptoms that they are in distress? Does their skin, as we look at it, does it have any paleness or cyanosis to it? What is the shape of their chest? We're also noting their respiratory rate, but what is their depth? Are their respirations shallow? Are they able to take deep breaths? What is their rhythm? Is it irregular? And we want to note that as we look at our patient. Do they appear like they're short of breath? Then we want to palpate. So we want to notice the skin temperature, and do they have moisture? Are they sweating? Is it possible they have a fever and that's why they have this increased respiratory rate? Do they feel cool to touch? Percussion is usually not often used by nursing. It's used by more of an advanced practitioner, but we can do percussion over the lungs, but I'm not going to go into great detail because, as I said, most of the time when you guys do your head-to-toe assessment, you will not be using percussion. We're going to auscultate our lung sounds. We're going to assess for airflow through the airways. What sounds are they having? And then the next slide, we're going to talk about what are adventitious breath sounds that we're noting that can draw us to conclude that they do not have good airflow. So when we're auscultating our patients and we're listening for breath sounds, we want to note if they have crackles. Crackles can be an indicator of fluid in the alveoli that sometimes patients have, especially if they've got a history of congestive heart failure or chronic obstructive pulmonary disease. And it sounds like a high-pitched intermittent popping. I always tell students crackles for me sound like if you have a bowl of Rice Krispie cereal and then you pour milk over the top and you hear the little popping. That is what crackles will sound like. If you have a patient and you hear crackles, you should automatically think fluid, that they possibly have fluid in the alveoli or in their lungs. Wheezing is this more musical, high-pitched sound. As we talked about with restriction in the lungs, a lot of times we'll see wheezing if they have that obstruction. So if they have some type of mucus buildup, possibly a foreign body, or if they have any kind of constriction like we see with asthma patients, we will hear that wheezing sound. We've assessed our patient, and your book goes on to talk about common diagnostic tests that we can do for our patients, depending on whether we think they have some type of issue with their lungs or with their heart. The first one your book talks about is an electrocardiogram. You can hear this referred to as an ECG. Sometimes you might hear it referred to as an EKG. And what we're measuring is heart electrical activity. And this can help us identify that myocardial infarction, or, if we think we're patients having a heart attack, rhythm disturbances, chamber enlargement, and even possibly electrolyte imbalances, because electrolyte imbalances can cause a dysrhythmia within our heart. And so that is a common, if we are thinking the patient has cardio or cardiac issues and that is affecting their oxygenation, we can, provide that recommendation for the physician and possibly get an ECG for our patients. The next test we're going to talk about is a pulmonary function study. These are normally conducted by a respiratory therapist, but it's a group of tests that assess respiratory function to assist in evaluating a respiratory disorder. And so my son, who is an asthmatic, every time he visits the allergist, we do a pulmonary function study. And they have him take a deep breath in. He puts this device that you can see in the picture here in his mouth, and they have him blow out as hard and long as he can. You can see the monitor in the background. It's taking the readings. When my son does this, because he's a pediatric patient, they'll usually have him look at the screen, and they have a picture of a brick house and some little pigs, and they'll tell him to blow as hard as he can to try to knock over the brick house. And what they're doing when they're doing that test is they're trying to evaluate his lung function. Because they already have diagnosed him with asthma or the disease. They're assessing how severe is his asthma currently. They're looking at what medications do they have him on as an intervention for his asthma, and are those working for him? What is his lung function with those interventions? And they kind of, his test, he goes every 6 months. They kind of assist in the management of his disease. So based on his lung function test, they can determine whether maybe we can stop using a certain medication, maybe we need to up the dosage of a different inhaler or medication. So they do provide valuable resources. And so you may see, if you have a patient possibly asthma, emphysema, COPD, they may want to do a pulmonary function test just to see or evaluate what is their lung function currently, and how severe is their disease. So our next device is a spirometer. We use this to measure, or can be used to measure, volumes of air in liters exhaled or inhaled by a patient over time. Your book talks a little bit about this on page 1496. But basically, if we're trying to evaluate lung function and airway obstruction through respiratory mechanics, we can use this to measure the degree of airway obstruction. And so the patient inhales deeply and then exhales forcefully into the spirometer. Now, if we're wanting to use the spirometer to promote deep breathing, possibly because our patient has just had surgery, maybe they have pneumonia and we're trying to get them to take a big deep breath in to inflate those lungs, we're going to use it just a little bit differently. And with that, we are going to always promote that they suck, they don't blow. So your nursing book, and I hope you'll take time to look at this, but has some guidelines for nursing care on page 1504. And this is how to teach your patient to use the sensitive spirometer if we're trying to get them to engage in more deep breath exercises, such as with a post-op patient. And basically, we have our patient exhale. We have them put the spirometer in their mouth, and we want to have them take a long inhale and hold that for as long as they can. Usually, we always try to come up with some type of test question on spirometry. So I highly suggest that you review that guidelines for nursing care, and you are very aware of how to teach your patient to use the spirometer for deep breathing. The next device we're going to talk about is a peak flow meter, that we like to call it, and we're measuring the size of the pulmonary airways, so that point of highest flow during forced expiration. We will see this a lot with especially patients with asthma. We will have them use a peak flow meter to measure that, and basically the patient takes a deep breath, um, and then they breathe, or they exhale as forcibly as they can into the peak flow meter. And we instruct patients to do this 3 times, and we record their highest number. And if you can see on the picture on this peak flow, we've got a red, yellow, and a green area on this. So depending on what the patient blows out, what their highest number is, we want our patients in the green. That means that their airways are open and they have good function. If we're in the yellow, that could be a warning sign. Maybe it's time to use their inhaler. Um, Maybe the air pollution or their allergies are really bad. They may need to take some allergy medication, but the yellow is more of a warning sign. And then if we have a patient who has asthma and they're using this at home and they're in that red zone, that means we need to contact the physician, that their airways are not open as they should be, and they do not have optimal oxygenation going on in regards to probably constriction from their disease process. So again, this is a valuable tool. And again, if you have a severe asthmatic patient, you're probably going to see that they need to use this during the day. I'm sure from doing vital signs in the skills lab that you already know what a pulse ox is, but this is measuring a patient's saturation of hemoglobin in their arterial blood. It is good to note that clients with low hemoglobin, they may have a normal pulse ox reading, even though they may not have enough oxygen to meet the body's demands. It is possible. It's something to keep an eye on. But this is what the pulse ox is measuring. I always tell students to highlight this, because I could see this being a test question that we ask you, what is the pulse ox measuring? And then a lot of students miss it. But we are checking this. Most of the time we want our patient to be 92% or above. There are cases when we're dealing with a COPD patient where their normal is 89%, and we're okay with that. Just because we already know with their condition that they're going to have that poor cardiopulmonary oxygenation. It's a factor because of their disease process, and they tend to run a little bit lower. But this is another way that we can, another type of diagnostic test we can do with our patients. We do not have to have an order for this. We can go in and obtain this with a set of vital signs. Capnography is the other one that I want to talk about here. Capnography, we are measuring the rate and depth of respirations and the amount of CO2 that patient is having come off when they exhale. We often use this with clients when they come out of surgery, or if they're on a PCA, which is a pain medication pump. And we want to measure their opioid-induced respiratory depression. So if you have a patient, and you can see it in the picture here, where they're on this type of pump for pain control, we are worried that they will go into respiratory depression. And we talk more about a PCA pump in our pain chapter. But we do want to monitor these patients, and so we will put in this tubing, and you can see it in the picture here on the left, and it almost looks like oxygen tubing if we were going to give patient oxygen, but it actually has a little bubble on the other end of the prongs, and that's how we know this is for capnography. So we know that this tubing, if we hook it up to the device here, the pump, that we can measure if that patient has the correct amount of CO2 coming off. If a patient starts to go into respiratory depression, it will monitor this and it will alarm us so that we can go in on that patient and check and make sure they are all right. You can give oxygen through this tubing as well, but I know a lot of students, when they go into the clinical setting and maybe their patient has this on because of the pain medications they're on, and students will see this tubing and they automatically think that their patient is on oxygen, and that's not always the case. This tubing does, like I said, look very similar to oxygen tubing, but it does have the little bubble on it, which means it's for capnography. It's a special tubing for that. The next diagnostic test we're going to talk about is thoracentesis. This is basically where we puncture the chest wall and we aspirate pleural fluid. We may be doing this procedure to remove fluid or air via syringe, or we may, the physician may want to connect that patient to a chest tube. So this is performed at the bedside. It is performed by a physician or a advanced practiced individual such as a PA or a nurse practitioner. Surgical asepsis is required. However, the nurse can assist at the bedside. Basically, the patient sits at the edge of the bed and kind of bends over a table, and the needle's inserted, and fluid or air is collected into a vacuum container. For the nurse, the reason we even kind of go over this test is you as the nurse will have responsibilities. You need to obtain a baseline vital signs before you begin the procedure. You're going to be there to support the patient during the procedure. You're going to want to try to have them remain calm and stay as still as they can. You're going to remind that client not to take a big deep breath or cough or have any sudden movements. And then post-procedure, you're going to want to be assessing that patient and monitoring for blood in the sputum, any respiratory distress, any severe coughing. You'll want to get a set of vital signs after that procedure is done. So, we've went over factors that can cause problems for our patients as far as cardiopulmonary functioning and oxygenation. We've talked about assessing our patient. We've talked about diagnostic tests we can do depending on the condition for our patient. And now, as nurses, we want to promote optimal function. So your book goes through some different things for promoting optimal function. One is health and lifestyle. Encourage our client to eat healthy. We want to encourage them to exercise, avoid things such as smoking, excessive alcohol use. Another one is to obtain their vaccines, a yearly flu vaccine, a pneumonia vaccine for adults over 65. Pollution-free environment, talking to them about environment. Again, my child has allergies and asthmas, and years ago I worked for an allergist, and they were always discussing for the children who had severe allergies to things, dust, if your child is severely allergic to dust, it's a good idea to maybe get rid of carpet in the house and have wood floors. Not having a parent smoke in the house would be good education. And so those type of issues or type of interventions can promote optimal functioning. We want to talk about good nutrition again with a patient. If we have a patient with certain disorders such as chronic obstructive pulmonary disease or emphysema, that patient needs a higher protein calorie diet because they have increased energy demands from trying to breathe. Positioning can be another thing. If we're having a patient that is not breathing optimally, we may want to place them in high Fowlers so that they can have good exchange of oxygenation. We're going to maintain adequate hydration for our patients. We're going to encourage water. This helps promote and thin secretions. And then sometimes even we can recommend providing some humidified air. So those are a few of some ways nurses can promote optimal functioning. If we want to promote proper breathing with our patients, um, these are some different types of breathing exercises we can do. There's deep breathing, where we encourage deep inhalation through the nose, and we have the patient exhale out the mouth. I've seen this done a lot with patients who maybe they're having an anxiety attack or just having some trouble catching their breath. Getting them to do this sometimes helps. We've talked about incentive spirometry for wanting that patient to have deep breathing. Um, and this also decreases atelectasis in our patients. And again, I have that guideline for how to teach that there. Pursed lip breathing. This can reduce dyspnea and anxiety. The patient exhales through the nose to a count of three, and then, they inhale through the nose to a count of three, and then they exhale through pursed lips to a count of seven. We've seen this done, especially with the COPD patient or the emphysema patient. Pursed lip breathing can sometimes improve their dyspnea. Diaphragmatic breathing. This has been known to decrease respiratory rate, increase alveolar ventilation, and may help expel as much air as possible during expiration. The person places one hand on the stomach and the other in the middle of the chest. They breathe in slowly through their nose, letting the abdomen protrude as far as possible. Then they exhale through pursed lips, contracting the abdominal muscles with one hand pressing in and up on the abdomen. Again, I highly recommend looking over these different breathing exercises in your textbook. Um, as as a student going in, you may need to use one of these with your patients. So it's important you understand when you would use this breathing exercise, what it's for, and how would you tell your patient to use it. This next slide is about promoting or controlling a cough if a patient has a cough. And it's important to be aware that coughing is a mechanism for clearing our respiratory tract of irritants and congestion. Um, and so basically, it causes an explosive movement of air from the lower to the upper respiratory tract. Um, Coughing can be good. We sometimes want our patients to cough. It's a cough is most effective when a client is sitting with their feet flat on the floor. It's important to be aware that sometimes a cough can be voluntary or involuntary. So when I think about voluntary, a voluntary cough is an important aspect of pre and post surgical care. If we're wanting our patient to deep breathe and use the spirometer after surgery, a lot of times when they do that, it will cause them to cough or loosen any secretions in there. And so that is important. We want that voluntary cough. For those that are unable to cough, there are manual stimulation that you can do for that. But at times, sometimes a cough is involuntary. Patients that are sick, maybe have a cold or some type of respiratory infections, and sometimes that involuntary cough can be disruptive. So the next slide we're going to talk about possible cough medications that can assist with that involuntary cough. So the one thing I want you to realize with cough medicines, they act in different ways. There are different types of cough medicine out there. Sometimes they are expectorants, and these are good because if you have a patient that's coughing a lot, this will help thin secretions, and it will make it easier for them to cough out or remove what's in there, that irritant that's causing the problem. Suppressants tend to depress the cough reflex. I know sometimes if patients haven't been sleeping well because of a cough, they've been up coughing all night. Occasionally, they may take an over-the-counter suppressant, but really, we don't want to suppress the cough constantly because it does serve as a purpose. Lozenges can help decrease the cough mechanism. But the important thing we want to teach our patients about this is to avoid prolonged use of cough medication. If coughing lasts over 7 days, we want to encourage that patient to visit their physician to figure out what's going on. The next intervention for nurses, suctioning of the airway. This can assist with removing saliva, pulmonary secretions, blood, vomit, foreign material from the pharynx. So it is used at times. A physician order is needed. We need to be aware as nurses, it irritates the mucosa and it does remove oxygen from the respiratory tract, possibly causing hypoxia. It can be painful and distressful at times. We always want to assess for that pain, and if we can, provide pain medication prior to suctioning. That's not always possible, but if we can, that's good to do. It's important to remember we're going to wear our PPE, our gloves, our goggles, mask, whatever is needed for proper protection when we're suctioning a patient. And then when we're suctioning, we want to monitor the patient's color. What's their heart rate? What is the amount and consistencies of the secretions we are getting out? Does their heart rate and their respiratory rate indicate they have hypoxemias? Because we want to watch for that. And you guys will be suctioning a patient, and it's important that you refer to your skills. The skill for suctioning is 39-2, and it's on pages 1528 to 1532. The next thing I want to go through is inhaled medications. Inhaled medications are administered to open narrowed airways, so you'll see this a lot with asthma patients particularly. There's several different types of inhaled medications that you can be given. We won't test you really on, for instance, a brand name of a medication. But as you go into the clinical setting, it's important to understand if they say your patient's on a nebulizer treatment, well, what is that? And basically, they take liquid medication, they put it in this machine that's at the top of this page, the picture that's at the top of this page, and it disperses fine particles of that liquid medication that the patient breathes in. The patient, if they're older, they can just put this in their mouth and breathe in and out while the medication's going. If you have a younger patient, you may see them put a mask to this and put the mask over the nose and mouth to get this medication. MDIs are meter-dosed inhalers. They delivered a controlled dose of medication with each compression of the canister. Common mistakes when patients give this medication is they fail to shake it before the dose, so it's important to teach that. They need to shake the canister. They need to hold the inhaler, they need to hold the inhaler upright. Sometimes they hold it upside down, which is not good. They inhale too rapidly when they're taking this medication. Or they stop inhaling and the medication just gets to the back of the throat. And it's important that they hold their breath after taking this medication. The reason I put this picture on here is the MDI is most effective when it's used in conjunction with a spacer, which is what this tube is here. So this helps that problem of that medication getting stuck to the back of the throat. The other thing is to teach the patient they want to exhale. They'll want to shake their medicine, put it on the spacer, put the spacer in their mouth, and they want to take a long, slow, deep breath. Then they will remove this, and they want to hold their breath for a count of 10, and then they can exhale. The last medication we're going to go over here is the dry powder inhaler. Again, this is breath activated. So the patient clicks the lever down on the medication that I'm showing in this last picture at the bottom. They're going to take a quick deep breath in, and that breath activates that powder for them to inhale. And so that's, if your patient's on one of these, I just wanted you to be aware of what they were, and how those devices work and the teaching involved around those. So this next slide's about supplemental oxygen. So if our patient has a low pulse ox, they are not breathing optimally, we can perform this intervention of supplying oxygen. However, oxygen is considered a medication and you have to have a physician's order for that. In some cases, such as, a patient comes in the emergency room and it's an emergency, the patient can be given oxygen if needed, but the physician has to be called immediately for that order. um, Oxygen can be supplied in many different ways, from wall units that you might see in the hospital to possibly a cylinder or tank that's portable. But basically, there is a flow meter that is attached to the wall unit, or on the cylinder or tank, and it has a valve, and that regulates how much oxygen that patient is getting. Canisters are nice because they're portable, but they can be heavy and burdensome to patients. Concentrators. So your book has a small section that talks about this, and these are used in homes. They are a little cheaper because they are taking concentrate oxygen from room air and recycling it, basically, so that the patient gets that through the device. It can deliver anywhere up to 5 liters of O2 per minute. So it's a nice option for that patient that's at home that needs to be on oxygen. It's a little bit cheaper than actually purchasing an oxygen tank or canisters. We always want to be careful with oxygen in the COPD client. And basically, hypoxia may be the stimulant that keeps them breathing. They have too much O2 may cause this client to lose the stimulus and they stop their breathing. So again, when I was talking about pulse oxes and normal ranges, this is the reason that sometimes we're okay with the COPD patient running in the 88-89%, because we know if we give them too much oxygen, we can stop their drive to breathe. So we want to be very careful with how much oxygen we're giving a COPD patient. Humidification can be added to an oxygen delivery system, and sometimes that is needed because that helps keep the mucous membranes moist. And basically, you're just adding a little sterile water to the flow meter or the valve as the oxygen comes out, and it humidifies it, and it does assist with a patient's complaining that their nose is feeling dry from that oxygen. It's always good to provide that. You do not have to have an order to add sterile water or humidification to if a patient's on oxygen. However, you do need an order for the actual oxygen. If you have a patient that's put on oxygen in the hospital, or maybe it's new, they're going to go home on oxygen, or maybe they already are, but it is good to reinforce teaching about oxygen precautions. So oxygen is combustible. We want to make sure that patient knows not to be around an open flame. It is advisable that they do not smoke when they're on their oxygen because it is combustible. We want them to avoid using electric razors. They can, we want to warn them about synthetic materials that could build static and cause a shock. And avoid using any combustible oils. So it's good to give that education to that patient. Like I said, if oxygen is new to them, they need this information. If they're already on oxygen, it's good to reinforce this information with them. This slide is about the different types of oxygen delivery. Depending on how much oxygen your patient is needing, it will determine what type of device that you will put on them. So the nasal cannula is the most common delivery device. This is for a low flow oxygen. And we can deliver anywhere from 1 to 6 liters a minute with this device. Again, this is where you can add that humidification that may need to be given. We want to be aware that the patient puts that, puts the device in their nose, and the tubing goes up along their face and over the back of their ears. So we want to be checking those areas to make sure that they're not getting any ulcerations or pressure areas, or that tubing's not causing any skin alterations on that patient. The next device we're going to talk about is the face mask. And again, I've tried to give you pictures here. So the top, the first picture is the nasal cannula. The next one is the face mask. And this, we want to fit comfortably snug, but we, again, want to make sure it's not too tight. And this is used to increase oxygen delivery for short periods of time. We can only use this with 5 to 8 liters of oxygen. And it will not be effective. We never use it with less than 5 liters. So if you're a patient only on 3 liters of oxygen, then you just need to put them on the nasal cannula. We don't need to use this face mask. This again is for a short period of time and can be used anywhere from 5 to 8 liters. The next one that we're showing here is the partial rebreather. This has a reservoir bag that collects the first part of the patient's exhalation. It mixes it with 100% of oxygen for the next inhalation. The rest of exhalation is released in the vents on the side. When we use this, we can, this is used with 8 to 11 liters of oxygen if your patient's needing that. The next one your book talks about is the non-rebreather. This is for when we need high concentrations of oxygen, like the partial rebreather, but this one has a two-way valve that prevents the patient from inhaling their exhaled air. We use this when a patient's on 12 liters of oxygen, or they're needing 12 liters of oxygen. And again, with each of these, the oxygen is a physician's order. And with that order, the doctor needs to be writing how many liters he wants the patient on, what's the max. If you've got your patient on 5 liters and that's what that's the max the doctor wrote for, and you feel like they need more based on their signs and symptoms, you're going to have to call and get another order to increase that and to figure out what device here that the physician wants them on. The Venturi mask has a large tube with an oxygen inlet. As the tube narrows, the pressure drops, causing the air to be pulled in through the side ports. Ports are adjusted according to the prescribed oxygen concentration for the Venturi. This is used when we need some high flow oxygen because it delivers very precise concentrations. This can be used for at 4 to 10 liters a minute, and again, it requires careful monitoring, but it is for patients who really need that precision of concentration and they need to be on high flow. Oxygen tents, commonly used with children. Your book does not talk about these anymore, so you don't need to worry about an oxygen tent. I did put a picture here to show what that might look like if you had a patient on it. There's also a table that talks about these oxygen delivery systems here on page 1511. It's table 39-4. The next device we're going to talk about is positive airway pressure. This uses mild air pressure to keep airways open. It's referred to, there's BiPAP and there's CPAP. BiPAP changes air pressure while the client breathes in and out. CPAP is continuous air pressure. This usually will fit over the client's nose and mouth if you have them on it. And it's often used to treat sleep apnea in patients. So you will see that on a patient that may have sleep apnea. This keeps their airway open at night. And I just wanted to do a quick overview of what that is. The next thing we're going to talk about is an overview of managing chest tubes. A chest tube is indicated when there's negative pressure in the pleural space or it's disrupted. And this can happen from a thoracic surgery or trauma. Patients with fluid, like such as a pleural effusion, patients with blood, such as a hemothorax, or air, a pneumothorax, in the pleural space require a chest tube to drain these substances, and that allows the compressed lung to re-expand. So all a chest tube is a firm plastic tube. It's placed in the pleural spaces by a physician. It's sutured into place. We cover it with an airtight dressing, and it drains that air or fluid from that area. Nursing responsibilities. So we're going to continually assess the respiratory status and pain status of our patients. We're going to observe that dressing around that site. We're going to palpate around the insertion site for crepitus. We're going to assess water seal for bubbling. And they go into more of chest tubes in Med-Surg 1. So again, this is just a little overview of chest tubes. You will get more in depth of how to care for chest tubes as you advance through the program. But when we're caring for these, again, we want to assess the water seal. It should be bubbling. We want to avoid milking the tube. So if we get some type of clot, you don't want to milk that tube to try to get that clot out of that tubing. This is and very important to remember. If the tubing becomes disconnected from the system, so meaning not from the patient, the tube's still in the patient, but it's not connected to the system, we want to immediately submerge the end of that tubing into sterile water. So that's why it's important to keep sterile water at the bedside. We also want to keep rubber tipped clamps and Vaseline gauze dressing at the bedside. And your book does give some really good guidelines as far as monitoring a patient with a chest tube and the guidelines for nursing care. And you can see that on page 1514. It's guidelines for nursing care 39-3. As we come to the end, or near the end of this chapter, the last few slides are about artificial airways. And so your oropharyngeal airway, this is a tube or a plastic or rubber, and we see this inserted in the back of the pharynx through the nose or the mouth. This is often used post-operatively, and it keeps the tongue from blocking the airway. So it's really important that the correct size is used as to not to hinder that airway. So again, this is just an overview so that if you see this, you understand what it is and what it's used for. So the next artificial airway we're going to talk about is the endotracheal tube. This is inserted into the trachea. A laryngoscope is used to insert. This is usually done again by an advanced practitioner or physician. We can use this to administer oxygen by mechanical ventilation. Most commonly, we use a cuffed endotracheal tube to prevent air leakage and bronchial aspirations. Once this is put into a patient, the patient cannot speak. And once we've put this in, often it requires suctioning to remove secretions. The last couple of slides here are about a tracheostomy. This is inserted for mechanical ventilation. It bypasses the upper airway if a patient has an upper airway obstruction, or to remove endotracheal secretions. And this is an artificial opening into the trachea, normally about the second or third cartilage ring. It can be permanent or temporary. The tube consists of an outer cannula and an inner cannula. There's an obturator that guides the direction of the outer cannula during insertion. Again, this can be cuffed or non-cuffed, but it's held in place with a Velcro strap or tape. And so there's nursing implications with this. Administering heat or humidified oxygen. We want to keep the trach free from foreign objects. We want to keep that clean and replace the inner cannula as needed. We want to do regular changing of the dressing and ties and assess and clean that skin area around the tube. Standard bedside equipment that should be kept at the bedside should your patient have a tracheostomy is the obturator, the suction equipment, oxygen, a manual ventilation bag, and a spare tracheostomy tube should that come out of the patient. Tracheal suction is one of the skills that is usually performed or taught in the skills lab. You should review that providing tracheostomy care. That skill can be found 39-5 on page 1540. And you should be reviewing tracheal suction, which is a skill on 39-6 in the back of your book. But when we do tracheal suctioning, we want to perform this using a sterile catheter. And we want to use sterile technique if we're in the hospital. If a patient has to do this at home, or a loved one has to do it for a patient at home, we usually recommend clean technique in the home. We want to, this can be very uncomfortable and it can be painful. So we want to make sure we administer any pain medicines prior, if necessary, and if it's not an emergency situation. The patient, when we are doing tracheal suctioning, is at risk for hypoxia, mucosal damage, dysrhythmias, infection, and atelectasis. So before we start the procedure, we always want to hyperoxygenate the client before and after each suction attempt. We want to make sure that we limit the suctioning to 10 to 15 seconds. That's what your textbook calls for, so we want to make sure we're not doing anything over that. We also, when we're suctioning our patients, we do not want to insert the suction tube more than 1 centimeter beyond the length of the tube that they have. Again, I find it very important that you go over that skill, look at those directions and that information. That concludes the end of this PowerPoint for this chapter on oxygenation. Thanks.